Good morning. Before I get started, I want to introduce myself. My name is Hary Lawall. I'm an ABC certified orthotist and prosthetist for Lawall, Prosthetist, and Orthotics. We have locations in Pennsylvania, New Jersey, Delaware, and now Florida. And the doctor just asked me to come up here and just talk about all the different kind of braces out there and kind of like the pros and cons of them. So who is getting a scoliosis brace? Typically, they're girls and guys between that have 20 to 45 degree curves. Their skeleton is not matured yet. And if we see some that are braced before that 20 degree because they're high risk patients, it's a history that their family has scoliosis. So the goal for all scoliosis braces is to make sure that this curve does not get worse. In order to achieve that goal, an orthotist must try to get at least 50% correction in the brace. The patient must, of course, wear the brace, and you also need a team approach. With the team approach, oh, sorry, I'm missing a slide. Okay, I want to talk about that team approach. The team approach is you need the family members to be supportive to try to embrace this TLSO. You also need a orthotist and a orthopedic surgeon to be on the same page. If the orthotist can't get 50%, they need to reach out to the orthopedic surgeon and find out if they see something that we don't, just don't kind of let it go. And the patient must communicate with the orthotist if the brace does not feel right or if something's going on, because we, of course, need that compliance. There's many types of scoliosis braces. They all have 3-point pressure systems. You got the Milwaukee Brace, the Boston Brace, Wilmington, you got the nighttime, Charleston, and Providence braces. And the two newer braces are the Rigo, Cheneau, and the Spine Core. The Milwaukee Brace, like Dr. Weinstein said, it's the oldest type of brace. It's used nowadays really if it's a high thoracic curve. That's pretty much it. All the other braces can control the spine just as well. The Boston Brace, that's one that is universally available, so the majority of orthotists throughout the country can do this. You can either get casted for it, it can go by measurements, or you can also do a 3D scan. It's used for all different types of curves, and it's research proven that this brace works. The Wilmington Brace is another brace that research shows that this thing works. It's basically the thinnest type of plastic you can do to control a spine. The problem with this brace is that there's not many orthotists in the country that do this. And also with the low temperature plastic, if you leave it in a hot car on a summer day, it'll melt. So you got to kind of watch that stuff too. So the nighttime braces are Charleston or Providence braces. They are designed for C curve, so just a single curve. They are proven to work. It comes in a variety of colors. The strap's in the front, which makes it easy to put on. But the trim lines are very aggressive for this, so it takes a little bit of time for the patient to be comfortable sleeping in it. The newest one is the Rigo Cheneau. It's a low-profile design. It's incorporated with the Schroth method of therapy, which I believe we're going to hear about next. And it's basically the newest type of brace. The pushes and the correction in this brace are pretty strong, I guess. But it's also it's a newer brace, so research is still ongoing with it. But it looks like the preliminary research is showing that this brace is going to work also. The last type of brace I want to talk about is the Spine Core. If you guys look at that thing, it's very interesting. It's a bunch of different straps. It's very hard for the patient to put on themselves. The patient and the parents need to go through basically a training process on how to even put this thing on. But it's a low-profile design. There's minimal plastic, and it's typically used for curves that are below 20 degrees. The preliminary research on this shows that the other stronger TLSOs do a better job than this. One of my slides is missing, but some of the questions I get, because I fit a lot of braces, is what do I wear underneath the brace? The question for that is really, whatever the patient feels comfortable with. You want some kind of thin barrier between the brace and the skin just to make it more comfortable. And then there's also questions on how long do I have to wear this? But Dr. Weinstein kind of explained that to us. So the biggest thing we're trying to do out of a brace is make sure that this curve does not get worse. To do that, the brace must fit properly. You must get that 50% correction, and it's worn as prescribed. Communication between the patient, the family, the orthopedic surgeon, and the orthotist is very crucial to make sure that everybody meets their goal. Anybody have any questions?
Yes, this is Nara. Oh, yes.